Morning, my name is Adriana Carrera. I talk about a 79 years old man with hyponatremia and involuntary movements of the arm and face. Definitions. A 79 years old man was admitted to this hospital because of the hyponatremia and involuntary movements of the arm and face. The patient and the being is usual state of health and the walking 3 minutes per day until 5 weeks before. The current admissions when fatigue developed during his daily walks. He began resting after walking a quarter mile because of the fatigue. There was no chest pain, dyspnea, and leg pain. Hyponatremia. In addition, he began taking naps during the day, which was unusual for him. 3 weeks before the current admission, the patient presented to his primary care provider for evaluation. Laboratory studies reported revealed hyponatremia. He was advised to the present to the emergency department of the hospital of further evaluation and the treatment. The video.
Hyponatremia in relationship to ADH. So no urine output with normal water intake. People that make no urine, doesn't matter what their ADH activity is. Compulsive water drinking with maximal but inadequate urine output. These patients have ADH maximally suppressed. And then normal water intake with decreased urine output. These are the patients that are ADH dependent. And this is what we're going to be talking about today. So remember, ADH shifts water from being excreted into the toilet and retains it into the body. And in these patients, that reduction in urine output means that they have more water intake than water excretion, and it causes hyponatremia. There are two physiologic stimuli for ADH release: increased serum osmolality and decreased perfusion. First, let's look at increased serum osmolality. This really is irrelevant when it comes to hyponatremia because this happens when you have increased osmolality or hypernatremia. So we don't need to worry about this when we're dealing with hyponatremia. In this case, all we're worried about is decreased perfusion from volume depletion or from hypotension. And these are what we're going to be discussing in the rest of the chapter. Hyponatremia from volume depletion and hyponatremia from hypotension. Hyponatremia due to volume depletion. This volume depletion can be due to GI losses like diarrhea or vomiting, or renal losses like diuretics. The mechanism of action here is you get volume depletion, leads to release of ADH, decreases the urine output, leading to an imbalance with more water intake than water excretion. Hyponatremia due to hypotension. There are three causes here: heart failure, cirrhosis, and nephrotic syndrome. All of these cause decreased blood pressure, decreased perfusion. All of them are edematous states, and those are all represent hypervolemia. Again, the mechanism here is identical. Decreased perfusion leads to release of ADH, leads to decreased urine output, leading to an imbalance with more water intake than water excretion. Hypovolemia and hypervolemia both have the same mechanism of action. These two conditions are more similar than different.
Symptoms. In the emerging department, the patient report no history of the orthopenia or the leg swelling. Tone his weight had increased by 2.2 during the past years. We report eating and drink normally, with no nausea, vomiting, or diarrhea. He had to the weekends lost the sensations, headache, or vision change. The video.
Well, when I was 12 years old, I only had a little bit of hand shaking, and we would go from doctor to doctor and not find any answers. And I just started to get worse and worse. I would shake, jerk, and not understand what was going on. Trying to write is nearly impossible, especially with one hand. And in the beginning, I had some Botox shots, but that no longer was working, the shots. So, and also the medication I'm on wasn't working fully. It was very difficult for me because as I would drink or eat, I'd spill my food all over. Try to drink, and I'd spill that. And emotionally, I would leave in restaurants because I was embarrassed. And I heard about DBS, and I thought it would be, something to look into, and I was just shaking a little too much and jerking a lot. Tomorrow is my surgery, so I just wanted to show everyone how I usually eat a bowl of cereal, and I usually have to go real close to the bowl, and I have to put my elbows on the table when I eat. If not, it would be really hard to eat. Well, the treatment was fine. I mean, they first did, Dr. Barba first did the DBS, and I would, be with, like, it was like a cage thing that they would put on your head. And so he told me that it was, you'll be fine, no problem. I was fully awake during the surgery. Since my DBS surgery, it's been so dramatically changed. I'm able to even get a job. I'm able to brush my hair and do so many things that I wasn't able to do before. I was told from a doctor, not Dr. Barba, but from a doctor that I would live with this forever. And I was like, I would pray and have people pray for me. And I really do feel that it's a miracle from God. I really do. It's changed my life more than you would know.
Medications. Medications included lisinopril, hydrochlorothiazide, and atorvastatin. There were no allergies to medications. We blood smoked tobacco in the mask, but had 14 years old. Earlier, they drank alcohol rarely and did not use illicit drugs. He was a retired teacher and lived with his wife in the New England. His family history included heart disease, his father and pancreatic cancer in his mother. I continue results. Laboratory test results are shown in table. The patient received 250 of intravenous isotopic fluid 4 hours later. The blood sodium level was 127 mol per liter. The patient was instructed to stop taking Indrol and to follow up with his primary care physician. He was discharged from the emergency department. Conclusions. In conclusions, initial differential diagnosis and around this finding Hyponatremia is the most common electrolyte in the hospital patients, and that there are many approaches to the easy evaluation 1 and 4. We consider the cause of the hyponatremia in any pain in as a series of questions to the narrow my differential diagnosis. The video.
Movement disorders is an area of neurology that deals not so much with strength or sensation, but more with complex movements. So walking, the ability to do a complex task like play the piano or write, those kind of things. So movement disorders as a group, it's a very prevalent group of diseases. There's estimated to be 500,000 people in this country with dystonia. There's estimated to be 1 million people in this country with Parkinson's disease, and more if you consider all the other Parkinsonian diseases. And then there's considered to be probably about 10 million patients with essential tremor. The care of movement disorders is very individual. There's really no two patients that are alike. Each patient has to be evaluated on an ongoing fashion to decide what is the appropriate treatment regimen, whether that involves injections, medications, or a surgical procedure that gives you the best effect for that individual patient. Parkinson's disease occurs because there's a dropout of neurons in an area of the brain called the substantia nigra, which results in a loss of dopamine, which is a neurotransmitter. So there are medications that either increase the amount of dopamine in the brain or medications that stimulate dopamine receptors. That's the first line treatment, because by increasing dopamine receptor stimulation, we can see an improvement in symptoms. Down the line, however, those medications may become ineffective or effective for very short periods of time during the day. So the patient has a very choppy day, an unpredictable day.